introduction. And thank you very much for staying up that late of the day. So very briefly, we're going to go over some few cases, challenging scenarios that we think everyone should know, especially when they're beginning their career. So first patient would be an 84-year-old, highly symptomatic patient, highly calcified, as you see from the annulus, above the annulus, below the annulus. There's an Katsianos score of almost 10,000 Hounsfield units, and very good left main height. So we're going to walk you through what we did, and so we can discuss. You don't have to agree with us on what we did. So based on the calcium, the amount of calcium, we decided that a self-expanding valve would be an ideal choice. Very gentle predilation. As you can see, it's not ideal. Our first implantation, there seems to be some kind of infolding. It seems that that the valve hasn't deployed well. So we did a post-dilation as well. And this is a very nice image. This bulging because of the calcium. End result is very good. Mild to moderate PVL because we had to do a T and C. However, the hemodynamics are ideal. So we do have great hemodynamics. We have a good outcome. We don't have the long-term valve durability. At 1 year, the patient's alive and well. Even though we had these kind of images with a stent protruding, it seems that the patient is good. So we need to remember these patients have an increased risk of angular rupture. Maybe self-expanding valves might alleviate the risk. And there's always going to be an increased risk of the PVL. Next patient would be a patient with a surgical bioprosthesis. So there was an 87-year-old patient. 10 years ago, more than 10 years ago, he had a surgical LabCorp 21. He was fine and well. Came back with symptoms, mixed AV disease. As you can see from the CT, you get to see where is the prosthetic heart valve. You see the sizes. You see a very good VTC, which is the distance from the virtual to the coronary artery. And we have the app from Dr. Bapat. We get to see as cardiologists how the surgical valves look like because we don't actually know. It does say here that the true ID is 19, but it's fractionable, so we keep that in mind because maybe we can put a bigger size when we are in our thought process. So this is exactly what we did. We decided to go with a new Resilia valve that has the new anti-calcified technology. So we didn't choose to go with the 20. We went with the 23. You get to see how nice we can see where the LabCorp is, the pinching. Of course, then we had in our mind that we will do a post-dilation, try to disrupt the LabCorp, and it seems that we actually had a very good result. And we can see from the hemodynamics, the echo, very good velocity and gradient. So we need to keep in mind there is going to be an interaction with the surgical and the transcatheter valve. There's always going to be a risk of coronary obstruction. Is it a self-expanding or a balloon expanding? The lower we go, maybe we should try for a self-expanding, but this is up for debate as well. The next patient would be a patient with a tight anatomy, usually old ladies, 86-year-old, very thin. You come to us with severe symptomatic AS. You get to see how small the anatomy is both in the annulus and the STJ, but that's not just it. She also has very high amount of calcium and with a borderline left main height. So in this case, we decided maybe up at that time we had some self-expanding valve. We decided to go with a navitor and intra-angular valve. And we did a very gentle balloon dilation. You see the valve is sitting nice and well with a very good result. And we have good invasive and echo hemodynamics. So patient with tight anatomy, we need to be aware of the patient prosthesis mismatch. There's always going to be a risk of coronary obstruction. Self-expanding or balloon expanding, the balloon expanding might have higher chances of PPM. Self-expanding, if you start to push, might cause too much pacemaker. Is it going to be a supra or an intraangular? Maybe data favors supraangular, but as you saw, intraangular valves are also very good at this patients. Bicuspid aortic valve, a lot of patients, almost 6 to 7% of these patients that we see have a bicuspid valve. They haven't been studied a lot, so we don't have enough randomized data. You see a right to left raphe in this patient. 69-year-old patient had a previous history of surgery for aortic coarctation. symptomatic, he has a bicuspid type 1. As you can see, Dr. Tsoumani told us very well, I didn't know you need to find the narrowest point, not just go 4 millimeters above the annulus. So this is our anatomy. So we tend, in our group, to follow an algorithm. If we can have a balloon predilation that fits well, there is no actually PVL, and there seems to be a good fit, maybe we could, and the balloon is not slipping up, maybe we could go for a balloon expanding valve as we did here with a new Sapien Resilia 26, and then we did a post-dilation, very good result, and good hemodynamics. So obviously we need to know there's going to be a risk of PVL because of the calcium and the ellipticity of the valve. There's going to be a risk of embolization because we tend to put these valves higher up. There's going to be a risk of angular rupture, stroke, and PCM, and don't forget these are young patients. And of course, always, as you can see in every little table, we have at the end of the bottom of the table the heart team input. That's the only gold standard. Patients with pure AR, yes, we see them a lot. Not very often, but they do come along. There's a 70-year-old patient with a previous bypass, had an endocarditis, now has a dysfunctional aortic valve. We do a CTCA, we see huge annulus, very, very minimal amount of calcium. And this case was a few months ago. We decided to go with a Meredith-My valve. We tried to go and oversized. This was a benefit of these valves, that we can have big sizes and oversize these valves. Good result. You see how long it takes to inflate that valve because we have a large annulus. We need to really inflate and overinflate the valve in order to have a good deployment, and you see a very nice result. End results, 0 AR, excellent hemodynamics. And this is what we need to remember for these patients. There's no calcifications, there's no anchoring for these valves. Oversizing is crucial. Now we do have data with both self-expanding and balloon expanding valves, and heart team input is ideal. Younger patient, does younger mean lower risk? In the most recent TVT analysis that we published a few weeks ago, only 7% of the low-risk patients were below 65 years old. However, this seems to be that the one-year outcomes, they seem to be on par with what we have published. But it's not just what valve we will choose to put. There's other things we need to consider for these patients. Is this 59-year-old patient your typical low-risk young patient? Not really, because not all of them will have Hodgkin's, radiation, hostile chest, and everything, but they do come along. And you see from the CT scan, you can see that this patient already had a first TAVI 70 years ago, so that's rather unfortunate. You get to see how the TAVI looks like. You get to see the calcium now that the new valve, the previous valve has. You get to see there's good VTC from the right coronary and the left coronary. Again, it seems to be an easy choice, but nothing's ever comes easy in this life. So you get to see, we think we're going to have an easy time. The balloon ruptures because of the calcium spicule. At the end of the day, we managed to have a Resilia 20. Very good result. Excellent hemodynamics. Just a word of caution for these younger patients. We need long-term data. We need to have very low pacemaker rates. We need to preserve coronary access for future access. Last slide is more better. More numbers, is it getting better? What we need to focus is that, yes, initially, the numbers are good, so we have very good outcomes, but as the time goes by, the outcomes need to be preserved by our skills. So, take-home messages, TAVI will be offered in more patients. Theme, CT imaging, and heart team is always going to be essential, and skills do take time to acquire. Thank you very much.
Thank you very much. Excellent presentation and very nice cases. Do we have any comments? Yes, Dr. Tradalis.
Excellent presentation, Kostas. I don't have any comments because I know that...
you can disagree, as we said. It's okay. It's part of...
No, I would like to tell one thing. Yesterday, I have done a follow-up of a 95-year-old gentleman that we have done a TAVI with Professor Toulgaridis 17 years ago with a core valve. And it seems that this valve was put in this patient yesterday. Has a maximum velocity in the aorta about 1 meter and 45 meters per second. It's a core valve, the first generation, and that lasts 70 years. 70 years. An excellent case to present. I think Professor Doudas will present in the following weeks. Thank you very much.
Well, you know, the patient should tell us his secret, you know. And then
Yes, Dr. Kilic.
The only durability data we have got is from the old generation valves. There are two valves, balloon expandable, XT valves and core valve. So this is very, very important. And in morning, there are some discussions about to do TAVI in younger patients. There are some studies which compares the TAVI results and surgical results in younger patients. But there is a bias there because we do TAVI in younger patients in a very high-risk population. So this can be, mortality can be high in these younger patients because we are doing TAVI in very, very high-risk younger patients. Thank you.
That's a great comment. We set the bar very high for ourselves. That's why we have great results, though. So, thank you.
Okay, thank you very much. We move on to Dr. Kalogeras.